Welcome to today's exploration into a topic that's changing the way PTSD is treated. Have you ever picked up the phone to finally ask for help, only to hear, "Sure, we can see you in 3 months"? That's the call we got last week. The caller can't sleep, startles at every sound, can't focus at work. Classic PTSD symptoms. Yet the first open therapy slot is basically 2 seasons away. Here's the surprising part. Some folks are finding real relief in just 5 short writing sessions. 5. Could something that brief actually work? Let's dig in. First, the problem. In most clinics, there's a canyon between what we could offer and what patients actually get. Picture a veteran who finally decides to face a blast injury memory. He discovers his therapist's calendar is jam-packed with hour-long appointments. A community clinician is already juggling 60 clients. Adding a long trauma protocol feels impossible. Primary care teams spot trauma every single day, but their 20-minute visits are swallowed by diabetes, back pain, and housing crises. They're desperate for a brief, evidence-based option they can deliver with confidence. Now, that option may be written exposure therapy, WET for short. It's short, it's scripted, and the training curve is gentle. That means health systems can slide it right into existing workflows, in primary care, with non-specialist clinicians, or even as a way to shorten long wait lists. Let's zoom out to the system level. Say a safety net clinic must screen for trauma. Every positive screen triggers a referral to a specialty PTSD program that's already 6 months out. Or imagine a rural VA site with one trauma specialist. When she's on leave, treatment stalls. Leadership starts asking, what can we roll out that won't break the system? The math is convincing. Each WET case takes under 3 hours of therapist time. So, in the hours it takes to push one person through a long protocol, a single clinician can finish treatment with 3, maybe 4 people. For clinics forced to do more with less, that multiplier is gold. Flip the setting to rural. One part-time mental health provider anchors a stepped care pathway. She delivers WET in person or over telehealth. A distant PTSD expert offers short case consults instead of direct treatment. Care stays local, travel burdens vanish, and the precious specialty visits are saved for the most complex cases. Health systems can tuck WET into other programs too. Post-deployment clinics, women's health, oncology. The protocol's tight structure makes documentation and supervision easy to standardize. That means leadership can actually track fidelity and outcomes across multiple sites. So the real strategic question isn't, can we afford another treatment? It's, can we afford not to use one of the few PTSD options that fits our staffing reality? When teams set clear inclusion rules, track basic outcomes, and keep supervision alive, WET shifts from a niche to a backbone of trauma care. Want a concrete picture? A large employer-sponsored clinic kept seeing workers injured on the job circle through crisis visits. They trained a handful of occupational psychologists in WET. Employees whose PTSD symptoms stalled return-to-work plans got a brief, time-limited series scheduled during flexible leave. In just 1 quarter, case managers logged fewer stalled disability claims and smoother transitions back to modified duty. Another example. A college counseling center drowning in mid-semester demand. Students with assault histories usually land on a wait list. Instead, the center now offers WET to those who want a focused, short-term approach. Most stabilize enough to keep up with classes. Only students with persistent or complex needs slide into those scarce long-term therapy spots. If you're on a wait list or live miles from the nearest specialist, imagine swapping months of waiting for a few weeks of guided writing sessions. For systems, the core idea is reach. One therapist, triple the patients, without cutting corners on quality. A quick reality check. WET doesn't replace longer therapies. Teams still need to screen carefully, offer options, and keep an eye on folks who need something more intensive. The research horizon looks promising. Studies are testing WET with translators, community health workers, even simple mobile tools so language, literacy, or bandwidth don't lock people out. Early data say dropout hovers around 1 in 10, far lower than many longer protocols, but we still need real-world clinic numbers. Step back for a second. If insurers and health systems start taking brief, structured care seriously, PTSD treatment could become as routine as blood pressure management, available early, in many settings, and matched to symptom severity. Think about it. The hardest part for most people isn't deciding to seek help. It's finding an open door. Before we wrap, let's get practical. Or if you're a clinician, try this 3-part reflection. 1. If you had 5 30-minute writing sessions, which single traumatic memory would you tackle first? Narrow it down to one manageable chapter, like the car ride before the crash or the moment you heard the news. 2. When and where could you protect 3 half-hour windows this week, phone off, door closed, tissues ready, to write every sensory detail as if it's happening right now? 3. Right after each session, which simple grounding routine will you use? Maybe drink a glass of water while naming 5 things you see, or take a short walk and notice your breath. 10 minutes later, check in with yourself. What shifted? If you're in crisis, don't go it alone. Reach out to a trusted clinician, a crisis line, or a veteran-focused organization and ask about evidence-based care. Mention written approaches as one option. So here's what we covered today. 1. The access gap is brutal. Months-long waits are common. 2. Written exposure therapy, or WET, packs evidence-based punch into 5 sessions and about 3 clinician hours. 3. That efficiency lets health systems triple their reach without adding staff, from urban primary care to the most remote rural clinic. 4. Real-world pilots, from workplaces to campuses, are already seeing smoother recoveries and lighter specialty caseloads. 5. WET isn't a silver bullet, but paired with good screening and supervision, it can anchor a stepped care model that finally makes PTSD treatment routine. Take a breath and picture the ripple effect if every clinic worldwide had that tool on the shelf. Here's my challenge to you. Whether you're a clinician, a policymaker, or someone living with trauma, ask this week, what tiny step could I take to make brief, effective care more available? Maybe it's forwarding this episode to a colleague. Maybe it's blocking that first 30-minute writing slot on your own calendar. Because the sooner that open door appears, the sooner healing can walk through it. Thanks for listening. I'm glad you're here. Talk to you next time.